For the latest information regarding the COVID-19 pandemic in Cupertino, please visit cupertino.org/coronavirus.
Hey, doctor, can you hear me?
I can hear you fine, Governor.
Honor. I don't know how you, anytime I'm feeling exhausted, I then just think of you, and I have no excuses, no nothing. Just gratitude to you and your example.
Thanks.
God bless you. I don't know how you handle the criticism nor the accolades. I don't know the triumphant quality that is all things you, and how grateful we are as a country and a world. So I really honored to be with you today.
Well, thank you. That's very nice of you. Thank you.
You guys ready? Tell us when. Ready? Hey, Doctor, thank you so much for taking the time to be with us. And I wanted just to start right off the top because of some news out of this state. Just an hour or so ago, we were informed that this new variant, this new strain that we've identified, obviously from the United Kingdom, some other parts of the globe, identified in Colorado yesterday, has been identified here in the state of California, in Southern California. And I know there's been a lot of conversations around the issue of virulence, the issue of transmissibility, but I'm curious more broadly on the issue of diagnostics, on the testing side, immunity. Have we received enough information to really understand the impacts in other categories, not just on the issue of severity of disease and the transmissibility of this disease?
Well, Governor, first of all, I'm not surprised that you have a case and likely more cases in California, and we likely will be seeing reports from other states. Colorado were the first to do that. I think you're going to start seeing it because if you have that much of a prominence of this in the UK with all the travel, not only directly to the United States, but through other countries intermittently, like where you go from UK to France, France to the United States, et cetera. Then Canada has cases. So I don't think that the Californians should feel that this is something odd. This is something that's expected. With regard to your specific question, there's a lot we know about it because our British colleagues have been studying it carefully. And there are things that we will soon learn more about them in a more definitive way, literally as the days and weeks go by. So the things you mentioned is that it looks pretty clear from the UK group that, in fact, the transmissibility of this mutant is more efficient than the transmissibility of the standard virus that we've been dealing with up to now. Namely, it's able to bind to the receptors on cells better and therefore is transmitted better. There's no indication at all that it increases the virulence. And by virulence, I mean the ability to make you sick or kill you. It doesn't seem to make it more strong in that regard. In addition, it doesn't seem to evade the protection that's afforded by the antibodies that are induced by vaccines. The other thing that they've noted in the UK is that people who have been infected don't seem to get reinfected by this, which means that the immunity that's given to you when you get infected is protective against this particular strain. And thus far, it doesn't seem to have any impact on diagnostics where you would miss it from a diagnostic standpoint. One of the things, Governor, we want to keep our eye out on is that since these are specific mutations, we want to make sure that they don't evade the protection of certain of the monoclonal antibodies, because the monoclonal antibody is against a very specific component of the virus. Whereas when you get vaccinated, the immune response that you make is called polyclonal, which means it's against many different parts of the virus. So even though you have one part of the virus that's changed, it is very likely that the other components of the vaccine-induced response will protect you. So that's what we know about it now, but we're following this extremely carefully. We have isolates from the UK. We're working on it here at the NIH and at a number of other laboratories throughout the country.
Yeah, it's interesting. In California, just to level set so people have a sense, we've been testing about 5,000 to 10,000 tests a week, genomic tests, with our partners, UCSF up here in Northern California, CZ BioHub partnership. And we've not seen that strain until, again, the news out of Southern California today. But because I imagine any mutation, it just scares the average person. The average person hears that variation, but this is not abnormal as it relates to these RNA viruses. I mean, how do you calm the nerves for those that have nerves around this issue?
Okay, so to all of my Californian friends, and I have many, they should realize that this is an RNA virus. In other words, the makeup of it is RNA. RNA viruses, they make a living out of mutating. They love to mutate. The more you replicate, the more you mutate. So when you have a lot of virus that's circulating in the community, it means it's infecting a lot of people. It's replicating a lot. And when you replicate, you mutate. The overwhelming majority of mutations are irrelevant. They don't have any impact on any important function of the virus. Every once in a while, you get a mutation that does impact a function of the virus. It appears from what we learned from the UK and what we'll prove here is that this particular mutation does in fact make the virus better at transmitting from one person to another.
Got it. Of all the things, and forget the politics, the atmospherics and all the surround sound, as it relates to the disease, this pandemic itself, what has surprised you the most over this last year? What has been sort of the stubborn reality that you've had to come to grips with more often than not that really distinguishes your experience and your expertise with this particular disease?
Well, Governor, I think it's something that we learned in the beginning, but we didn't know right from day one. Most viruses that are respiratory viruses, they're driven by people who have symptoms, people who sneeze on you and cough on you and all that sort of thing. What we began to learn sort of at the end of January, beginning of February, and then as we got into February, is that even though the Chinese were giving us information that really was a bit misleading. First, they said it's generally from an animal to human. It's not very efficient human to human. Then it was, well, it can go from human to human, but it's mostly people who are symptomatic. And then they began to say, now, wait a minute, we're seeing that even people without symptoms are transmitting it. And that, to me, is something that was the game changer. It was the game changer in everything we did. It was the game changer in testing, because you can't just test people who are with symptoms, because you're going to miss the asymptomatic people. Number two, mask wearing became much more important, because if you're only worried about somebody who's symptomatic, then you know who you're dealing with. But if you don't know who's infected, then everybody should be wearing a mask, which is the real fundamental rationale for saying we need universal and uniform wearing of masks. So to me, that was one of, I guess you could use the word surprising. It was a combination of surprising and disturbing.
Yeah.
The other thing that has really been an issue is that I've never seen a virus like this, and I've been dealing with viral outbreaks for the last 40 years, where you have such a range of involvement of seriousness from 40% of the people who get infected and have absolutely no symptoms at all, to those who have symptoms. About 80% have mild to moderate symptoms that generally require staying at home for a few days, maybe sometimes a couple of weeks. And then you get about 10 or 15%, not 10, maybe 20%, 20 to 25% of the people. That's, a quarter of the people who get symptoms, get severe enough symptoms that they may require hospitalization, intensive care, intubation, and they die. Hence the 335,000 deaths that we've had so far. So usually when you have a disease that is so virulent, it can kill people, not just old people and not just people with underlying conditions, but now we're starting to see even some more younger, relatively healthy people can get involved. And I think every one of us know someone who has gotten sick and has died from COVID-19. The mystery of how you can have so many people who have no symptoms and so many people who get seriously impacted is one of the reasons why we have a messaging difficulty, because most of the people who do well are young people. And they say, what do I got to worry about? My friend gets sick. They don't even know they're sick. My friend gets infected and he's out of action for 2 days and then he's back. And they don't see the people who are in the intensive care units and who are dying. So they say to themselves, why do I need to interrupt my life and interfere with a normal life when I need to get shut down? And that's the reason why there's that, in some respects, dichotomy of people that sometimes takes political connotations. Like you wear a mask if you're on this side of the group and you don't wear a mask if you're on the other. Yep. The uniqueness of, I've been through many, many crises for public health. I've never seen some infection that has been in the middle of such divisiveness. That makes public health messaging and public health implementation extremely difficult.
And Doctor, you say that in everybody's full knowledge of your involvement with HIV and AIDS, which certainly had a political component, but you suggest nothing like this, huh?
No, not at all. There was the in many respects, shameful stigma with AIDS for a while, particularly among men who have sex with men in this country. There was the lack of paying enough attention to it in the early years, when in the very early years of the Reagan administration, with all the many good things that President Reagan has done, the fact is they didn't put enough of the bully pulpit of the presidency to warn people that this is a disease that is not a problem of people, it's a problem of a virus. But other than that, it wasn't anything like the divisiveness that we're seeing right now, which really makes implementation of public health measures and public health messaging very difficult.
Yeah, no, I can concur. I can assure you. There's no daylight in that point of view in the practical application. We're in a state that's, in population terms, is larger than the populations of 21 states combined. And with a form of government, a system of government, where we put a lot of pressure and responsibility and accountability at the local level, local county sheriffs, rural, urban, all of those traditional divides. And so you're right, the mixed messaging has been a challenge, not just from the top, but also looking subnationally, state by state, but looking within states and looking at those realities in the application. From your perspective, did you see, 6 months, even 6 months ago, did you think we'd be where we are today, 300,000+ lives lost? Or did you think that we would get it and get something done more impactfully in terms of mitigating the spread and transmission of this disease?
Yeah, I thought the latter, Governor. I was very disappointed. What I was hoping that we would see is that when we had the real serious challenge in the late winter and early spring of 2020, when New York was really getting hit badly and they were sort of dominating the situation in the country, I would have thought that as we came down to a baseline, we'd get down to such a low baseline that we'd be able to contain these blips that occurred. But if you go back historically and look at the evolution of the outbreak, we had the big hump, as it were, in the late winter and early spring. But instead of going down to a very low baseline, it went down to a baseline of 20,000 cases a day, which is a lot of cases of infection. And then we went along at that level and we decided appropriately that we were going to try to open up the country. We wanted to bring back the economy. So it was open up America again. Yeah. And we put together a number of guidelines that I spent a lot of time with my colleague, Deborah Birx, and others on the task force. Gateway, phase 1, phase 2, phase 3. That would have been great, except that given the federalist approach in this country, multiple states did it very differently. Yeah. So instead of opening up and going down with the baseline, we went up to 70,000 cases a day. Then it came down to 40. And then when the cold weather came, we just went right off the roof. And now we're at 200,000 to 300,000 new cases a day. So what surprised me and really disappointed me so much was that I thought if we would get down to a really, really low baseline, as we had these individual little blips, we could do identification, isolation, and contact tracing, and we'd be in good shape. The only trouble is when you have 70, 80, 90, 100,000 community cases on a given day, it makes it almost impossible to do effective identification, isolation, and contact tracing.
Yep.
So we've been hit badly, and unfortunately, California has hit right now, currently, as bad as anybody, if not worse.
Yeah, our positivity rate, not as bad as many other states, but we certainly have seen the impact in our ICUs and hospitals in certain parts of the state, Southern California, San Joaquin Valley, Central Valley broadly, and that's certainly the case. It's interesting, you talk about contact tracing. 5 months ago, we were all talking about contact tracing. We were putting together a contact tracing workforce, and we partnered with UCSF and UCLA and started training workers, and we got a lot of our state staff to contribute. But a lot of folks aren't talking about it right now, and I think it's the point you're making is the magnitude now of the community spread puts so much pressure and makes almost the incapacity to substantively trace now, isolate, and quarantine. Is that point the point you were making, or is that should we actually double down now on the isolation, contact tracing, despite those headwinds, despite the magnitude of the community spread?
Yeah, I think we should try as best as we can. But the thing I think that we really need to do more of, and I've been saying this, is we need to flood the system with testing, particularly now when you have antigen tests. That there was a report recently in a scientific journal that showed that the Binex test has a much better degree of sensitivity for picking up people who might be transmissible. So I think if we just very, very much utilize that testing in schools, for teachers, even ultimately for the students intermittently, you could get a good feel for what the penetrance of infection is, and you can do something about it. So rather than individual identification, isolation, and contact tracing, which we shouldn't abandon, there's still a role for that. I think we should put much more emphasis on community type of surveillance testing so that you get a feel for where you are with schools, with prisons, with nursing homes. That's the way to go, because this virus is spread in a way that's without symptoms of many people. And you're not going to get to them by only testing people with symptoms.
The issue of PCR versus antigen, and you're making a case anew for antigen testing, despite some of the false positive debates. It's interesting. It's sort of, someone described to me the difference between the tests in sort of layman's terms, like an X-ray or an MRI. We keep focusing on these MRIs, these PCR tests, when X-rays may work just for broad understanding of community spread.
Exactly.
What do we need to do more? Is it just, folks in positions like mine just need to make the case anew, or FDA needs to do that? Or we all, what's been the friction point on broader distribution and recognition of the potency of antigen versus PCR testing?
That's a great question, Governor. I think it's a multifaceted reason. I don't think there's been one reason why we've not done it. I think it's just a gradual evolution. Now we're starting to realize some of us realized it all along, but we're starting to now putting the pressure on. We really need to do this. We've shown that when you do that kind of testing, like in universities and colleges, the ones who've done it right have a very low level of infection, where you can just continually screen. And then when you get somebody who's infected, you pull them out of circulation, you keep them isolated for a while, and then you bring them back, rather than closing everything down when someone gets infected. That doesn't work well. And we've proven that it doesn't work well.
Yeah. You talked about schools a moment ago. Today we rolled out our plan for safely reopening schools. What do we say, and I've heard some of your public comments around the importance of default for in-person instruction, for socio-emotional, not just data and intellectual purpose or academic purely rote, but on the basis of also the epidemiology and the basis of spread or the lack thereof comparatively. What do you say to anxious parents? I've got 4 young kids. We have 2 anxious parents at home. That includes me. What do we say to the millions of others? What do we say to the teachers that are still very worried, particularly when you have substantial rates of background and community spread, that we can honestly do this safely?
Yeah, we can do it safely. And I think there are 2 elements to that. One is the safety of the children, and it's the safety and concern, appropriate concern, that the teachers have. So as you know, you alluded to it, Governor, just a moment ago, my stance has been that we should use as our default position getting the children back to school and keeping them in school by putting together a program of supporting ways to prevent infection, by giving the schools and the teachers the resources that they may need to do that, including what I was alluding to just a moment ago of testing them and doing testing of the teachers and of the students in a surveillance way. We know something that we didn't fully appreciate several months ago, that unlike influenza, where the children get infected and they come home and they infect the parents, it looks now like if you look at the school as a unit where people are versus the community and the home as a unit where people are, the children in school seem to be doing better when it comes to the level of infection than whatever going on in the community. So that was almost counterintuitive, but it's turning out to be that way. So with that as an epidemiological bit of data, what we should do is to do everything to support the maintenance of the children in school for several of the reasons you mentioned. There's so many reasons for that. Psychological for the children, the impact on working families. I mean, if you really want to get society back to some form of normality, one of the first things we have to do is to get the children back in school.
Yeah, no, I appreciate it. Doctor, I'm very sensitive to your time. Just a few additional questions. I mean, the top question we're all getting right now. And I'm of the humble opinion we all should be a little humble because I think it's an extraordinary accomplishment. And I want to just congratulate you and all the team, Vice President on down, on Operation Warp Speed. I think it's an extraordinary accomplishment. The idea that, I was here in February learning about this virus. It was Corona, it was C9. I didn't even understand it. We had a Princess cruise line off the coast of California. We were starting to bring repatriation flights from Wuhan. No other state wanted those flights. And we were just grappling with the idea that now we've already applied and administered over 300,000 doses, I think is extraordinary. So I say that with respect that is, I think, deserved and is well earned by all of you that made that possible. But there's been some frustration, a little bit of frustration. We may have overpromised a little bit in the short run about the availability and the distribution of the vaccine. Have you adjusted based upon some of your previous comments where you expect we will be? I know we've gotten into herd immunity conversation. Is it 70%, 75, 80, 85%? But moreover, what's your sense? What do you say to someone who's looking out and is just hoping they're going to have a 4th of July like they had 2 years ago? Or is it really a September, October reality of some semblance of normalcy? Are we behind a number of months, or are we within a margin of error, 3rd quarter, 2nd quarter of the next year of hitting close to herd immunity?
Okay, no, you've asked a lot of questions, but they're all connected, so they'll be relatively easy to answer, Governor. So first of all, I had a good conversation at 7:30 this morning with General Gus Perna, who, as you know, is the person in Operation Warp Speed who's responsible for the delivery of the vaccines. And he admits that we're a bit behind, but what he believes strongly that in any massive undertaking, like the initiation of a massive countrywide vaccine program, you're going to get some bumps in the roads and some hiccups. And we believe, and he believes, and I trust him. He's somebody who is the kind of a person who is he's all into this, and he's doing everything he can, and he's good at his job. He feels that as we get rolling, we're going to be able to catch up. So the original proposal was 20 million doses, 40 million doses for 20 million people by the end of December.
Right.
where you would give 20 million doses and hold 20 million back for the second shot.
Right.
So they've delivered 11 million doses. And there have been about 2 to 3 million people who've been vaccinated. That's below the 2020. But as we get into January, the feeling is that we're going to gain momentum to be able to catch up. So that my feeling then is, let's assume, Governor, that we do catch up. And I'll answer the rest of your questions, which are all important questions. If we go through the priority people, we started off with healthcare workers and people in nursing homes and long-term care facilities. The next level were 75 and older and people who are critical to the running of society. And then the third level and the fourth and the fifth. By the time we get to the priority people, it likely will be the beginning of April. I would say end of March, beginning of April. So let's say at April, it will be what I call open season, namely anybody who wants to get vaccinated can get vaccinated. If we then diligently vaccinate people in April, May, June, July, that we will gradually and noticeably get a degree of protection approaching herd immunity, which I believe, first of all, no one really knows what absolute herd immunity is for coronavirus. We know what it is for measles because we have decades of experience with measles. So I would say it's somewhere between 70 and 85%. I believe that if we do the kind of vaccines through April, May, June, July, that by the time we get to the early fall, we will have enough good herd immunity to be able to really get back to some strong semblance of normality. Schools, theaters, sports events, restaurants. I believe if we do it correctly, we will be there by the early fall.
That's encouraging. And final question. A lot of asked, lessons learned, 1918, 1919, so many ways, some similar contours, the politics, the politicalization of masks, even back 102 years ago. Some of the issues around surge. Some have suggested we're in a second wave. Some have suggested this is a third wave. Some have suggested it's insignificant debate. But there is a sense that there's a hopefulness, rather, not just a sense that this may be the last big surge. And some have described a surge on top of a surge. You have. Others, surge on top of a surge on top of a surge, with the prospect now of Christmas, Hanukkah, obviously the holidays, more broadly defined, New Year's. Do you believe this is the last big surge that we will have to battle through?
Governor, I can tell you that, again, you can never guarantee anything, but I believe strongly that if we pull together as a nation and do the kind of public health measures seriously and uniformly up into and beyond the time that vaccines kick in, I believe that we can crush this outbreak within the time frame that I just mentioned to you. I really strongly believe that if we get people vaccinated, and let me use my conversation with you to encourage my friends and colleagues and everybody who I don't know in California, that if you have the opportunity to get vaccinated, please get vaccinated. It's a safe and it's a highly efficacious vaccine that could save your life, the life of your family, and the community. So I believe with those two things, adherence to the kind of things that you've been talking about in California, the public health measures, and as we gradually get more and more people vaccinated, we're going to be looking at this thing in the rearview mirror. I'm very confident that if we do those things right, that will happen.
I appreciate it. And forgive me for belaboring just one quick question, because we're in the midst of this intense dialectic, not in the midst. We've been for many, many months on stay-at-home orders, on guidelines, modifications to how businesses operate. I come from a private sector background, restaurants, hotels, bars, and wineries that have all been impacted. So it's not an intellectual exercise for me as an entrepreneur before I got into elected office, and the impact, the emotional impact, not just financial impact, of people whose entire dreams are on the line in terms of that entrepreneurial mindset and the impact it's having on their families and those that they employ and they support. There's this intense debate we're all having around the issue of the economy or public health. And I've heard you say it before, and it's so important if you can just help amplify the public health message is the gateway economic message to get us exactly where you just described we're about to go.
You said it very well. I've been saying this now for, 9 or 10 months, ever since we tried to so-called open up the economy again. And that is, we need to use public health measures as a vehicle, a gateway, a tool to get the economy back. It isn't the economy versus public health. It's public health bridging you to getting the economy back. That's what we've got to realize, and not say, I don't want to do this because I want the economy to open. You will open the economy when you get the level of infection down, and the only way you're going to get the level of infection down before the vaccine kicks in is by the public health measures that you have been talking about and that we all have been talking about.
I appreciate it. And let me just close, as only a former San Francisco mayor can, by quoting the late, great Jerry Garcia of the Grateful Dead, who was asked, or rather once stated, that you don't want to be the best of the best. You want to be the only one that does what you do. That is a great way to describe you, Dr. Fauci, a national treasure. I'm humbled, honored, and so grateful for everything you've done for our country. Thank you.
Thank you, Governor. Thank you for having me with you. It's been a pleasure to partner with you on this.
Thank you. Take care.
For the latest information regarding the COVID-19 pandemic in Cupertino, please visit cupertino.org/coronavirus.